So the first speakers are going to be Dr. Sally Adams and Dr. Lisa Chung. Sally is an RN and has a PhD in psychology and is a specialist in the Department of Adolescent Medicine at UCSF. Lisa has a DDS and an MPH from here at Berkeley and is a recent diplomate of the American Board of Dental Public Health and is an associate professor at UCSF. So with that, I'd like to welcome them up.
Okay. I'd like to begin by thanking the organizers of this symposium and for creating this joint forum and inviting us to come and share a bit about our project and how we've utilized a transdisciplinary approach to improving oral health for mothers and their babies. And we endeavored to do this by integrating oral health into prenatal care. And in the spirit of transdisciplinarity, I'm pleased to be able to co-present with my close colleague and mentor, Sally Adams, Dr. Sally Adams from the School of Medicine. As you all know and have heard throughout today's talks, that oral health is important, and this is particularly the case for pregnant women for a number of reasons. Pregnancy confers an increased vulnerability to oral health problems, and after babies are born, women can transmit carriogenic pathogens to their infants, and that results in an increased risk for early childhood caries. Now, the association between periodontal disease and adverse pregnancy outcomes, it's been subjected to a number of studies, both observational and experimental, and the results are mixed. However, the larger clinical trials show no evidence that providing periodontal therapy during pregnancy results in reduced adverse pregnancy outcomes. So while we cannot say that providing periodontal therapy will reduce pregnancy adverse outcomes, we can say that providing periodontal care is safe and it is recommended. So here are some examples of the problems that pregnant women may experience. And pregnancy gingivitis on the left. On the right is a pyogenic granuloma, which occurs in about 10% of pregnant women. Pregnancy gingivitis is much more prevalent. It is the host tissue's response to plaque, and because of pregnancy hormones, it's exacerbated. However, it's largely preventable if the pregnant women can maintain good oral hygiene. Now, the transmission piece about bacteria from the mother or caregiver to the infant is well documented. Women that have high levels of strep mutans can readily transmit their bacteria to their infants through common parenting behaviors such as sharing spoons, bites of food, and licking off the pacifier if it falls to the ground. So counseling and educating around these modifiable behaviors can reduce that transmission. Despite the reasons to maintain good oral health during the perinatal period, we know that many pregnant women do not visit the dentist. In California, 35% reported not having had a dental visit during their pregnancy. And the reasons and the barriers to care are they're numerous and they're complicated. And they can include things such as the lack of understanding of the importance of oral health during pregnancy, and also in difficulty in finding dental care providers that will treat them. However, in the same sample, 96% of the women reported having had a prenatal care visit during their first or second trimesters. And so this represents an opportunity. From this, we know that family physicians, obstetricians, nurse midwives, and nurses can sometimes be the only health professional consulting pregnant women and their families about promoting a healthy pregnancy. These health professionals can play an important role in emphasizing the importance of oral health. They have frequent and recurrent visits, and it also is a time when pregnant women are more receptive and open to receiving these health-promoting messages. This idea of utilizing non-dental health professionals, such as prenatal care providers, It's a way to expand the oral health workforce, and it is highlighted in this Institute of Medicine report. In fact, it's the first of their 10 strategies that they recommend to improve access to care for vulnerable and underserved populations, such as pregnant women. Furthermore, utilizing prenatal care providers has been promoted by national organizations, and some states have even developed some clinical guidelines that include a section for prenatal care providers. And to go into a little more detail with these clinical guidelines, they recommend prenatal care providers to assess and refer, to promote and educate around oral hygiene and dietary practices, as well as emphasizing that dental care is safe during pregnancy, and also anticipatory guidance for the infant around cleaning, feeding, and saliva sharing practices. So when it comes to prenatal care, most are familiar with the traditional one-on-one provider-patient model. However, the group approach to prenatal care is gaining popularity and attention. Centering Pregnancy utilizes a group approach. CP is an innovative group model of prenatal care, and it empowers women and advances their health and of their families through knowledge and building skills. So not just education, like Dr. Benzian spoke about earlier, but also providing the skills and the setting to enable that to happen. So because of CP's success, a new program extending beyond childbirth into parenthood has been developed, which is called Centering Parenting. So they're both part of the Centering Healthcare Institute, a nonprofit national organization. There's over 300 sites across the U.S. CP's effectiveness has been demonstrated and is associated with these perinatal outcomes. And a little bit about the CP program design, to give you some background idea, is that it centers around 3 key elements. Assessment is the first one, and that's assessment. Both the women assess their own health, and also they receive an assessment by a trained healthcare provider. Education, there are 10 2-hour sessions throughout their pregnancy, and it happens in groups of about 8 to 12 women that are grouped by similar gestational age. These sessions are conducted in a circle format, and it's led by a facilitator. Oftentimes the facilitator is a nurse midwife, and they're meant to be very interactive, not very didactic, and fun and engaging, and really lively discussions in a very social setting. Support. There's a lot of built-in socialization at these meetings, and food is always provided. We know that food is always a great way to share with each other. The educational curriculum, it includes various health topics that are important during pregnancy. However, we discovered that oral health was not comprehensively nor consistently being addressed. So that is what led to our study, Centering Pregnancy Oral Health Promotion, or CPOP, as we like to call it. And it's a pilot study funded by the NIH, and the goal was to improve oral health of pregnant women and babies, and to integrate oral health into CP and be scalable so that it could be implemented broadly in other CP sites across the U.S. Our team represents multiple disciplines in nursing, behavioral science, dentistry, public health, obstetrics, gynecology. And our specific study aim was to develop and pilot test an oral health intervention for CP prenatal group model of care. The first phase was a development and training phase, and that was really important for us to be sure we included the input of important stakeholders. And we did that through meetings with CP facilitators and also focus groups with women that were part of the CP groups at that time. Then we had the pilot test and evaluation phase, and that happened at 4 CP sites in the San Francisco Bay Area, 2 intervention, 2 control sites. One of each were Spanish language or English language sites. So during this first development phase, we followed the precede-proceed planning model, and we worked in close collaboration with CP. And we had CP collaborators as co-investigators, and that was really essential to establish important community partnerships in the CP sites, in our 4 CP sites. We also engaged CP facilitators in soliciting their feedback, so they had a really integral role in developing the intervention with us. They're the experts on CP and how the groups are run, and they provided really good feedback on the style, how to deliver it in the setting, even the activities that we would do and the different skills building activities. We also held focus groups of CP pregnant women for their feedback on the intervention content, as well as the study procedures to conduct the study in terms of how best to administer questionnaires and whether they would accept having a dental exam. And so this ended up resulting in a 2-session curriculum. There were brief interventions, and one was about maternal oral health, and the other one was about infant oral health. So the CPOP intervention shares many similar characteristics with the Fit for School example that was discussed earlier, and the 3 S's of being simple, scalable, and sustainable. We really held those qualities close to mind when developing this. And so they're 2, like I said, they're brief. They're 2 15-minute modules, and they're incorporated into 2 of the 10 sessions, the 3rd session and the 7th session. They're facilitator-led, so we train the facilitators, and they then deliver the intervention. It's interactive, and it's consistent with their style of being discussion-based. Educational plus skills building. It's brief, low cost, and sustainable. And all of these things will help enable it to be scaled up when we're at that stage. So the training, we trained 6 certified nurse midwife CP facilitators in the CPOP curriculum. So they helped develop it, then we trained them. It was a 2-hour group training session where we demonstrated, and then they were able to practice with each other. We developed these 1-page facilitator guides. They expressed the need for some kind of some prompt or a cheat sheet. So we developed these simple 1-pagers that they could use, and during their delivery of it, they had a practice session, and then we evaluated them and provided feedback.
So after all of the training was completed, we moved into the next implementation activities, which included participant recruitment, collection of baseline data, which include clinical dental exams, and completion of questionnaires. The interventions were delivered in 6 of the CP groups, and then we conducted post-intervention data collection activities, which were repeated dental exams and questionnaire packets. For evaluation, we used the pre and post data that we had from the women during their pregnancy experience in CPOP. And then we also had 2 postpartum assessments. So for the maternal outcomes, for their oral health outcomes, we use the dental exams from the pre and post period and knowledge and attitudes and behaviors. For the mothers and the infants, in terms of salivary assays, those were postpartum assessments again at 6 and 12 months. We're going to share some results now that include findings from our baseline study, our feasibility outcomes, and some of the clinical oral health outcomes. Most of our sample consisted of low-income Hispanic women that live in the San Francisco Bay Area, and most of the women were using public dental insurance and had more than a high school education. Our first study that is published, it's a baseline paper. We wanted to look at oral health status at baseline among this group of pregnant women. We found that 45% of the women in the sample had untreated caries, and that there was highly disproportionate percent of the women with untreated caries and gingival disease were in our Hispanic communities, those with public dental insurance, and those who had not had a dental visit within the last 6 months. We were interested in looking at healthcare utilization as a potential mediator, and we did find that a lack of a dental visit in the last 6 months partially mediated the effect between the social and racial and ethnic disparities and the health outcomes for the women. Our 6 facilitators were very enthusiastic about the trainings. They felt that it had great value for them for increasing their knowledge and ability to help women during the CP groups. They really liked the content. They really thought the time involved was all right and that it was very useful information that would be really helpful to the women. One barrier that we do encounter is that they recognize also when they add a half hour of intervention time into a basically sort of 20-hour curriculum that some other topics have to get adjusted in time to some extent. And we monitored the fidelity of the intervention, and they did a fabulous job covering 98% of all the objectives together as a group. The participants really liked the study also, and were very satisfied with the oral health modules, thought they were very helpful. And they mostly were able to tolerate the dental exams. They were a little bit harder for the women at the post period, which maybe they were 7 months pregnant. About that time, it was more difficult to go through the exam, but they did quite well with it. So now I'm going to show you some of the clinical outcomes. The first set of slides show the direction of change from pre to post for the intervention group and for the control group. The blue bars are the intervention women, and the red bars represent the control women. And this slide shows you that 70% of the women in the intervention group improved on their plaque levels from pre to post after they received the oral health intervention, and about 40% of the control women improved their plaque levels. What sort of surprised us was that we found, and a very consistent pattern across all the outcomes, is that women in the control group actually tended to develop more problems and more burden from the pre to post period. And this shows that 55% of the women in the control group actually had higher plaque scores in the post assessment compared to about 30% of the intervention women. Again, this pattern is the same for level of change in the pocket probing depths, with close to 60% of the intervention women improved on their probing depths, where close to 75% of the control women actually had increased levels in their probing depths. And the same finding that we found for the bleeding on probing, which almost 80% of the women in the intervention group decreased their percent of bleeding on probing sites that bled when probed, and about 50% of the women in the control group actually had an increased percentage of sites that bled when probed. These next slides are a little different. These represent the degree of change from pre to post in the intervention and the control group. So the blue bars are pre and post for the intervention women, and the red bars are pre and post for the control women. And you can see there's a small decrease in the mean plaque index for the intervention women compared to the control women. These differences are all quite significant. This group of analyses I'm showing you are based on generalized linear model, mixed models, and this slide and the next two ones actually the findings are controlled for the nesting of our sample, because we had women nested within groups, nested within facilitators, nested within sites. So these values and these significance of change of these changes take into account all of the nesting. For mean pocket probing depth, we had a decrease as a whole on the group that was significantly greater for the intervention group than the control group, and you can see that they, as a group, got a little worse on that. And then for the mean bleeding on probing pre and post values, again, the intervention group had quite a decrease in their percent of sites that bled on probing compared to the control group. This slide shows you the 12-month prevalence for Mutans Streptococci among the different infant groups that we have. The first bar, which is blue, are babies whose mom completed the CPOP intervention, and the next is the CPOP control babies. The next two bars, the mauve and the light mauve, are new samples. We needed to get some new samples, because our control moms, we were good citizens, and they got some of the intervention materials after the pregnancy intervention was over. But also, both of our CPOP groups had been through 2 dental exams and lots of questionnaires about their attitudes and their behaviors and those kinds of things. So we wanted to get an unbiased sample, at least groups that had not been exposed to our intervention, and the last 2 groups represent that. So overall, in the sample, the prevalence of MS at 12 months was 24%. And you can see that these sample sizes are fairly small, but you can see that the intervention group had quite a bit lower overall percentages for exposure to MS compared to the control groups, any of them. A similar pattern shows for exposure to lactobacilli, and again, 15% overall of this full sample of 92 women had exposure and prevalence for LB. In terms of knowledge, attitudes, and behaviors regarding infant oral health, both the control and the intervention groups increased significantly on their knowledge about infant oral health factors. And it's not surprising in a way, because there are a smattering of things that get covered in CP about infant oral health. Over the study period, the intervention group had greater increases in understanding the importance of oral health for infants compared to the control group. And then at 12 months postpartum, the intervention group was more likely to report that they had initiated brushing their infants' teeth, and that they reported they were more likely also to clean their infants' gum on a daily basis. The study has some limitations. It's a small pilot sample. Participants were not randomly assigned to study group. And the postpartum assessments included a subsample of the original CPOP intervention groups. In conclusion, we feel that a brief education and skills-based intervention delivered by non-dental providers in prenatal care may be effective in improving women and children's oral health. So next steps for us are to continue with the analyses of especially the salivary assays. We're working on that with Dr. Ling Zhan. And we've submitted an R34 planning grant, which would help us prepare for a UO1 clinical trial. And we'd be very interested in finding some time to be able to develop and expand the utility of this intervention so that it could be implemented in other care settings. I just wanted to quickly acknowledge our CP partners and Sharon Rising, who's the founder of CP, the NIH, NIDCR, UCSF, the Can Do Center has provided a lot of support, and the Dental Trade Alliance Foundation. Thank you.